Good morning, everybody, and thank you for joining us today. My name is Mark Driscoll. I am the program manager for the Preventive Health Program with the Ohio AAP. I'm just going to start us off with some of the basics today, and then I'll kick it on over to our panel. If you want to advance to the next slide. We have 4 great members of our panel today. We have Dr. Anna Mitchell of University Hospitals in Cleveland, Dr. Nancy Leslie of Cincinnati Children's, Dr. Rocky Gupta Basaray is of Nationwide Children's Hospital, and then the medical director for the AAP's Preventive Health Program is Dr. Chris Bowling. Thank them all for joining us today. This is just our CME disclosure to show that no members of this panel have any financial relationship with ineligible companies to disclose. And then the next slide discusses our DE&I initiatives. So we are working towards having a more robust diversity, equity, and inclusion standard for our presentations. So we've taken that into account when making this presentation. And if you have any questions or comments about that, you can email Dr. Bowling here at this email address. And then with that, I'll send it over to Dr. Bowling to go over our objectives for today.
Welcome, everybody. Really glad you're here. We have some very robust objectives for today's presentation, so don't be too intimidated by this. In general, what we're trying to do is just go over newborn screening from 3 perspectives: from the newborn blood spot, for the hearing screening, and for the cardiac screening. And we're also here as you may have noticed from our materials promoting today's webinar, we're really looking for input from you guys also. The Ohio AAP, the Ohio Department of Health have gone on this venture about screening, really wanting this to be a two-way street. Not only do we want to help get people informed on where things are, we want to hear from you and ways that we can make newborn screening more effective and efficient for you. So we really hope that this will be interactive today. With that, I'm going to turn this over to Dr. Gupta Basaray, and she's going to talk first off about critical congenital heart disease and screening. So take it away, Rocky.
Thank you, Dr. Bowling. Good afternoon, everyone. So I'll talk briefly about the newborn heart screen, or the CCHD. This is probably a refresher for many of you, but please do drop any questions that you might have in the chat box if anything comes up. So the screen was actually first recommended by the AAP in 2011, and it was designed to screen for critical congenital heart defects. And those are defects that require intervention or surgery in the first year of life. So it's not designed to pick up on all heart defects. Things like a VSD will be missed by the newborn heart screen. It became adopted for all babies in Ohio to be screened in 2014. And we actually have a pretty high pass rate, 99.9%. But it is helpful to know that the sensitivity of the screen is actually right now only 50 to 76%. So that means 25 to 50% of babies with a critical heart defect will be missed by this screen. Some heart defects, coarctation of the aorta, may present with a normal oxygen saturation. But even with that, the CCHD has been shown to decrease mortality related to critical heart defects by 30%. So it is a very worthwhile test, or screen rather, to be done. And it can also pick up on other non-cardiac disease like PPHN, or persistent pulmonary hypertension of the newborn. So it is recommended to be done at 24 hours of life, ideally in the newborn setting if a newborn is on room air. It can be done before then if a family is going home, and it could be done after then if a baby is born at home. It is an oxygen saturation comparison of a pre-ductal site, or the right upper extremity, and a post-ductal site, such as the foot. And it is acceptable for one location to be screened, either the right upper or the foot. But the AAP has moved to really recommending both oxygen saturations be evaluated. A pass would be a value greater than or equal to 95%. and a difference between the two sites less than or equal to 3%. So I always emphasize with my students that if we have an oxygen saturation in the right upper extremity of 96% and in the lower extremity of 100, even though both of those values are great, it's technically not a pass because that difference is greater than 3%. In which case, if a newborn does not pass on the first screen, the recommendations are for them to be rescreened using the same approach in 1 hour. And if they were to not pass at that time, you do have the option of getting an echo after the first or after the second screen, or you could screen again for a third time after another hour. And if they were to not pass at that point, the newborn would definitely need an echo prior to being discharged, ideally. And then it would be an immediate fail, and you would not rescreen if you have an oxygen saturation that's less than 90% in either the hand or the foot.
Thank you very much, Dr. Gupta-Basaray. So I'm going to turn this over now to Dr. Leslie, who's going to talk with us about the blood spot screening.
Okay, so although the comprehensive newborn screening program includes point of care things such as hearing screening and the congenital heart disease screening, what most of us think about when we think about newborn screening is what we put on a blood spot and send it off to the lab in Ohio. It's in Reynoldsburg, which is just east of Columbus. So almost every talk I have ever given over the last, not going to disclose how many years, starts with the original Wilson and Youngner newborn screening criteria, which have been around for a long, long time and are worth starting with, but they're a little bit aspirational even today. So those are that we should be screening for something that's an important health problem. We should not be screening for things that are benign. There should be an accepted treatment for patients with recognized disease. So we should not be screening for something for which we can't do anything about. The facilities for diagnosis and treatment should be available. This is one reason why, although it's very feasible to do screening for PKU in sub-Saharan Africa, they do not have treatment available, so they actually don't do it. There should be a recognizable latent or early symptomatic phase. We should not be screening for something that an astute clinician can recognize. There should be a suitable test. This is actually going to become a little more controversial as we go through the rest of the slides, or examination. Screening should be acceptable to the population. We should be not invoking things that people do not accept or do not want. This is my favorite. The natural history of the condition should be understood. That one should come with lots and lots of emojis if we had one for aspirational, because even now in 2024, we do not totally understand the natural history of a lot of the things we screen for, but it's a nice aspiration. We should have an agreed upon policy on whom to treat. Oh, that one's a little aspirational too. We're still trying to figure that out for some things where it's not clear. But there should be an acceptable cost and benefit. Acceptable, of course, is an interesting word. Some of the things that we screen for have very, very expensive costs to detect and vary per case because it's rare, and very, very, very expensive costs to treat. If we think about gene therapy for SMA, these provisions were, of course, designed at the time when we were talking about treating PKU, and at the time we thought that all we had to do was give people formula for 5 years, which, haha. The last point, I think, is probably the most important. There should be ongoing learning regarding case finding, and that is something that we actually do systematically all the time. So next. So if you had looked at what screens were offered by various states in the late 80s, you would have found that it was quite a patchwork. If you were born in Pennsylvania, you got one set of screens. If you were born in West Virginia, you got another. If you were born in Indiana, you got another. If you were born in Montana, you might get another. So the secretaries, it's now called the Advisory Committee on Heritable Disorders in Newborns. It's had quite a few names. That's the current one. And this committee advises the Secretary of Health and Human Services on the most appropriate application of universal newborn screening tests, technologies, policies, guidelines, and standards. So there is now a federal advisory group that has a standard procedure for deciding what to recommend. And the goal is to have, next slide. The goal is to go through this process, which is similar to Wilson and Youngner. Is the condition serious? Can a case be defined? Is there analytic validity? In other words, does our screening work? Is there clinical utility? Does it matter? Are treatments available? And this piece is theirs alone. Is there prospective data to support the process through population screening? So, in other words, they got to have some real world data that this actually works on blood spots that are collected from newborns at about 24 hours of age. Next. So what they have come up with is called the RUSP, or the Recommended Uniform Screening Panel. And the goal is to have predictable and a uniform set of conditions in all states. Now, again, my favorite word, aspirational, is true, because there are things on the RUSP that states who are independent entities are considering, but haven't yet been able to apply. So although the goal is for everybody to consider using everything that's on the RUSP in their application. On any given time point, you might not have total compliance. And this is actually true in Ohio right now. There are things on the RUSP that have been approved for development, but are not yet in use. The initial set of conditions for the RUSP was vetted by a stakeholder survey, which was committed by the American College of Medical Genetics. And it was highly focused on at that point, the developing idea that we didn't have to have separate bacterial inhibition tests for example, for phenylalanine and for methionine on different plates, but we could use a mass spec and get a whole bunch of things at all the same time, which is still true. And this happened about 1990. They sent out surveys to a whole bunch of people. I got one of them. I filled it out. They didn't vet my credentials. They didn't tell me that I really shouldn't be commenting on endocrine things, although I did, because I actually have those credentials too, but they didn't know that. So it was sort of a survey. It was, you know, it was what it was. And the original RUSP was developed across that. There are still things on that original RUSP that no longer fulfill the credentials for what would be included now. And there are a few things that have actually been newborn screened because the data, once again, that was we should have ongoing evaluation. They've been de-diseased. There was significant criticism of this original process. It was expert opinion, maybe. It didn't fit what we regard as our current model of evidence-based decision-making, although in rare disease, which is what most things on the newborn screening are, we are talking about things where expert opinion might be the highest level that we can come up with. So the new process, which is an excellent process, quite frankly, includes nomination, which can come from a variety of stakeholders. If they accept a nomination and go to evidence review, they actually have a very strict process for what they review. They have evaluation of pragmatic capabilities. At the time when it became obvious that we could probably screen for SCID or immunodeficiency, it was very, very difficult to get the equipment to extract DNA from thousands and thousands of blood spots per day. And when Wisconsin did their pilot, they were actually using a pipetter that did 8 at a time. We have robots now, but pragmatic capabilities are really important. And then it gets signed off by the HHS secretary, and then the states take this data and decide what they're going to do with it. So that's how things get on the newborn screen, and some of the considerations. Any questions in the chat?
There we go. I'm sorry, guys. Can you hear me? Am I back?
You are back.
Okay, I'm very sorry about that. We had a little technical difficulty there. I apologize. So Nancy, did you finish this slide?
Yes, I did.
So a quick question for you. I'm sorry to interrupt, but can you tell me, just by way of explanation, what is an example of something that was delisted?
Well, let's see. Severe combined immunodeficiency, actually SCAD, short chain acyl-CoA dehydrogenase deficiency, was on the secondary panel, and it is now considered a non-disease, so it is now delisted. The other thing that was the original list included tyrosinemia, which type 1 tyrosinemia is actually a very severe disease that causes liver failure in the newborn period. And everybody thought at the time that we could use tyrosine, which we knew how to measure, as the primary analyte. And it turned out it was a total fail. And we couldn't. And so we had tyrosinemia on the RUSP, and we're basically pretending to screen for tyrosinemia type 1 until somebody developed a technology for what we use as our primary analyte right now, which is succinylacetone. Once again, that was that last point on the Wilson and Youngner that says we should continually strive for process improvement. There are all kinds of things that we thought we knew that we didn't know.
Gotcha.
So the RUSP does include the tests that are done on the dried blood spot, as well as routine hearing screening and the pulse ox testing for critical congenital heart disease.
Great.
So I wanted to go just over the numbers as to what we are actually looking at. So there are about 4 million babies born in the United States that have some kind of screening, and most states are at least mostly compliant with what's on the RUSP. The ODH screened 129,344 specimens in 2022. That's a little down from our peak birth rate of about 140,000 a few years ago. About 1,600 of those screens were repeated for various reasons. There were about 190 that were rejected as unsatisfactory. That usually means that there isn't any blood on this on the spot, or there's something wrong. It's an unacceptable specimen. There were about 3,300 flags. In other words, something that got reported out to the primary team, excluding hemoglobinopathy trait, which is counted separately. And there were 129 confirmed cases of something across the spectrum of what we did. We also found about 362 other carriers and conditions that are not on the newborn screen. For example, it's not uncommon for us to find cystic fibrosis carriers. That's not our goal, but we do find it. And one of the things that is difficult for the lab and really needs input from the practicing community is that they had 1,700 cases that were still open. They did not have final data back to close those cases. This is very difficult. And part of it is our technology has gone faster than our ability to handle the tax. So for example, what the lab would like is a copy of the diagnostic testing. Well, all of us who work in the modern electronic medical record know that often these things are actually complex. Printing them off, finding a fax machine and sending it back to the state is not something that's in our usual flow. And we need to figure out a better way that is convenient for the people out in the field to provide their data back without making it just a huge burden. That's my soapbox for the day. I'll get off of it now. So process, what happens when something gets flagged? So the state, at least in Ohio, the state will call and fax to the PCP of record. That is whoever is listed on the newborn screen. We all know that people put providers on there that they have no intention of ever going and seeing, but it is the limitation of what we have. Often there's another designated entity like the genetic centers or the sickle cell centers or the cystic fibrosis centers will get a copy of the fax on the fax machine as sort of a courtesy. They do have a process for critical values. I can tell you from firsthand knowledge that if they get something on a Saturday that looks like it's this baby could be really, really sick right now, they will reach out to just about anybody they can find. Yes, on a Saturday afternoon. Usually not at midnight because there's nobody in the lab at midnight, but and we had a process for deciding what would be critical and which conditions and what level of abnormality would be called out that way. Following a flagged newborn screen, a baby might require a repeat screen, might require diagnostic labs, might require an urgent visit, and once again, I'm sort of thinking about the critical one that we had here in, I think it was Labor Day. It's usually a holiday, where we had to send the baby to the emergency room and get them admitted to the NICU right away. The family will be counseled, the diagnostic labs will be ordered, and a plan will be developed. And there is a process in the Ohio Revised and administrative codes as to what to do if you can't find the family. And then, of course, back on my soapbox is that we need you to help us close the loop by faxing the diagnosis and test results back. Next slide. A lot of the stuff that we're testing for is genetic, but molecular diagnostics, although they are part of the initial evaluation, they are not the primary process. Currently, the only testing where we do molecular testing as the primary thing, the first thing that the blood spot goes into a machine, is for SCID and for SMA. And there we're looking for absence of a particular piece of DNA. We're not doing any sequencing. We do second-tier testing with sequencing in some labs. New York is probably the capital of all them. They have had a very well-equipped, comprehensive sequencing program on that original dried blood spot, and they are the source of a lot of the new data on how to use sequencing. But we don't have that capability in Ohio. And we are not able to do any sequencing first disorders, but there are research efforts to do so because there are some things that do matter, and we would have to use DNA sequencing as our our first pass. We do have I thought I changed that. It is a panel for 39 common cystic fibrosis pathogenic variants. We're not supposed to use the word mutation anymore. And that is performed in the lab before reporting if the primary marker, which is immunoreactive trypsinogen, is elevated for cystic fibrosis. Therefore, if somebody, most of our CFs are reported out as we found 2 pathogenic variants, or we found 1 and an elevated IRT, you should go get a sweat. Or we didn't find any and we're not quite sure why we're flagging this. Next. So what's new? What's been added recently? Krabbe disease actually just got evaluated by the RUSP for several iterations. And I don't think it's been signed yet, but we started this in 2016. And this was an initiative from families, basically. Krabbe is a devastating neurodegenerative disorder. It's treated if a baby is identified and confirmed to have this diagnosis. They are referred for a bone marrow transplant, preferably done before 4 to 6 weeks of age. Mucopolysaccharidosis 1, which most of us learned to be called Hurler disease, is done by enzyme analysis, and Ohio began screening for that in 2017. Pompe disease is a muscular dystrophy that's also a lysosomal storage disease. We started that at the same time as MPS 1. Spinal muscular atrophy wasn't officially launched until 2022, but we were in the validation phase since 2018, and most babies were tested during that validation phase. And then the newest one that we have added is X-linked adrenoleukodystrophy, and we began the high volume validation in 2022 and launched slightly later that year. That was approved by the Newborn Screening Advisory Council before the pandemic, but we had a delay in implementation, partly because the pandemic, it interrupted a lot of things. X-linked ALD is keeping us in the field very, very busy these days. And then the newer things that we will talk about a little bit later, not quite implemented. Duchenne is not on the RUSP, and Ohio will be the first state to do this statewide, and we'll initiate this very soon. Mucopolysaccharidosis type 2, that's Hunter disease, only in boys, and will be added soon. And then something you may have never have heard of, which is called GAMPT, and I won't say the whole word. It's a creatine synthesis disorder. It's treated with supplements and a diet. It's extraordinarily rare, but worth looking for.
So thank you, Nancy. That was really, really helpful. And I know we're going to have a lot of questions. So please put your questions in the chat box. Mark and I will be answering those. And we're going to be turning these over to our panel as we move along. Just a quick word on the Ohio Revised Code and where this means. The Ohio Revised Code is the legal regulations around newborn screening. And it really echoes some of the things that Dr. Leslie was talking about. How do we determine what's going to be on the newborn screening? The Ohio Revised Code also has a very similar thing. I'm not going to bore you all with the legislative numbers, but there are similar sections that are present for cardiac screening, as Dr. Gupta-Basaray talked about. The other thing that also has an Ohio Revised Code is mandates for hearing screenings. We're going to talk about the hearing screenings when we go through our case reports here in a moment, case studies. But the revised code is the legality around it, and then it sets up the OAC, or the administrative codes, which really go through the particulars on how we do the screening. With all of these around cardiac screening, hearing screening, newborn screening, there are specific exceptions for religious exemptions. There's also around Krabbe's disease, Nancy mentioned how devastating that illness can be. There's also a sort of a carve out, and I'm anxious to hear Nancy's take on that one. I didn't quite understand why there is a carve out for that one, like there are carve outs around these other religious exemptions. Nancy, would you mind addressing that at all before we move on? If you happen to know why Krabbe disease is
Yes.
out.
So Krabbe was added at the request of the legislature. And part of the bill basically said that they realized, well, I don't know what they actually realized, but they put in the provision when they said that we would be doing this, that families could opt out. Right now, there is a religious objection. You can opt out of all screening if you say it's against your religion, but there aren't any other, carve-outs in the Ohio Revised Code. So Krabbe was, and whether or not that opt-out will stay there, once this is fully ruspized, I don't know.
Interesting. I just thought that was an interesting aspect to it.
Yeah. Remember that old thing in the Wilson and Youngner about it must be acceptable to the population. I think it was very, very acceptable to families affected by Krabbe. And they gave passionate testimony in front of many, many legislatures about the importance of that. But a rapid bone marrow transplant is not necessarily in everybody's cup of tea, maybe, for what they would find an acceptable treatment.
Makes sense. Thank you. So the administrative code we just talk about, and again, this the same thing goes. There's the religious exemptions that were built into the revised code. The administrative codes, which are really put together by ODH, is officially a document of the director of ODH, but then it's also comes from an advisory panel of 14 members selected by and reporting to the director of ODH. And again, the Wilson-Younger criterion are pretty much what are used to determine how Ohio is going to do this screening. I won't go through all the particulars here, but you get the general picture. So let's talk about, I think we always learn more when we talk about specific cases. We have several cases to go through, and I'm going to ask certainly our experts on the panel here today, because we have them. Dr. Mitchell from Case Western is on. Dr. Gupta Basare is here, as we mentioned, and as is Dr. Leslie. So we're going to go through these, and I'm going to actually ask the three of them to chime in here, as well as those of you on the call. Please, if you have questions, please use the chat box. And in fact, before we even get started, I think we have one in the chat box already, right, Mark?
We do. So I'll go ahead and read through those. There's a couple of questions here. The first is, how can we routinely get newborn screening reports?
Dr. Mitchell or Dr. Leslie, do you have any thoughts on that?
I actually have a slide on that in the supplemental slides. So maybe we can
Sounds good.
Put that one
go
later.
To that, or we can go to it right now if you want. Let's go down to it. Everybody's getting a sneak peek of where we're headed here.
Yeah, you're going to see all our slides. There you go. Okay. There is a website you can sign up for. It is great. It means that as soon as the report is finalized, you can log in, and it's an honor system. You basically are using your HIPAA honor system to say, yes, this is your patient. It is wonderful. You can get the report, if somebody transfers to your practice, and, you didn't get the original report, and there they are at 2 months of age, and you just need it. It's there, and you can literally The only difficulty with this is because it's got protected health information in it, you have to change your password. So, you know, you could have an account for your office, and, you know, several different people could access that account, but you have to be on the same page as to whether or not what the password is going to be. But I've been using this forever and I love it. I use it all the time because, of course, none of these are going to me as a primary care provider. I'm not one of those. And we don't have anything similar in Kentucky or Indiana. And this has been available for a while. Now, you can't go back and find something that's 10 years old. It's not maintained that long.
And you just get this by going to the ODH website?
And you actually ask for an account.
Gotcha. Great. Mark, there
Thank
was
you.
another question?
And our other
Thank you.
question is, how do you suggest that you handle newborn screening for kids that are born at home?
Well, I believe the Ohio Administrative Code says that the birth attendant shall cause a special specimen to be collected. We have lots and lots of lay midwives in our Amish population, and they actually get cards from their local health department. But we do recommend that you get it done. Actually, my very latest, like, was seen this morning, new real live PKU was a home birth, and so this baby is now 2 weeks old and getting into care. So the specimen was delayed, but it did happen, and it's a good thing because otherwise, you know, prognosis would be terrible for normal intellectual development.
So we have a great message in there from everybody's favorite neonatologist, Dr. Henry Akinbi, chimed in and has put the website in there for us as well. So thank you, Henry. It's good to see your name on today's webinar also. So let's dive into our first case here. So this is brand new, our new screening for Duchenne muscular dystrophy, and there are some things that are different about this. So let's talk about baby Lee, a 30-week preterm newborn male delivered at Metro General in Cleveland. Has an inconclusive DMD screen reported from his newborn blood spot test. So an inconclusive screen for muscular dystrophy, what's next? How about our experts? What can you tell us? What's next? What should we be doing next? Dr. Mitchell, any words of wisdom for us?
I think is definitely want to try to figure out in terms of what's the likelihood that this could be real. So in terms of repeating your CK or something to try to get an idea of whether how likely it is that this is a real screen.
So getting a CK. Do you guys anticipate, this is such a brand new thing, like how should pediatricians respond to these positive DMD screens? Because we don't do anything right away. So, or do we? How should we handle these?
This one's hard. There is nothing about getting delivered through the birth canal that makes your muscles happy. And so it is well recognized that CKs in a 24-hour-old baby are higher than they are in a toddler running around your office. And that most of this will resolve in 2 weeks. On the other hand, we don't have a good process for collecting specimens at 2 weeks of age, which would be a much better time to do that. So what we're having to do is we're measuring the CK on the initial dried blood spot. And if it's above a certain threshold, we are calling it inconclusive because you can't evaluate one at 24 hours of age. And we're asking for you to either get a CK, in a local lab, which you could get back the same day if you wanted to, or to send back another newborn screen. And we don't usually ask you to send back another newborn screen, but in this case we are. In discussion with the family, the reason it's being called inconclusive is because just that, it's not positive, it's not abnormal, it's not unusual, it's just we can't evaluate it. If the first screen comes out completely normal, maybe the baby's a C-section baby, or maybe they just lucked out and they're the bottom half of the bell curve, there won't be a flag. But the estimate is that we're going to have about somewhere between 1,300 and 2,000 babies a year statewide who are going to get flagged this way. And the other problem is we don't really have a whole lot of data on preemies who have low muscle mass. There were a couple of false negatives in, I believe, the New York pilot. So right now we're also asking for a repeat in low birth weight babies.
So is inconclusive the most that we'll get? That'll be
Yeah,
the strongest reading that we'll get.
Yeah.
Okay, so that's considered a positive, I would guess you'd say. But obviously there's a lot of false negatives, and possible for false negatives, positive for a lot of false positives.
Mostly false positives, a few false negatives, and we'll wind up, because we're the first state to actually do this statewide. We'll figure out what we can do about the small babies. But Henry and Dr. Kinby is actually he's a member of the Newborn Screening Advisory Council, and he's been one of my great partners as far as NICU babies and their particular issues with newborn screening. But this is one where a lot of those babies are going to still be in the hospital, and we'll be able to get that done before they go home. For them, we're worried about false negatives. For the term baby, we're worried about false positives. And we're not calling it false positive, we're calling it inconclusive.
Yep.
And that's just softer language than abnormal. I don't think we have a better term. So I think for the pediatrician, they really need to focus on the idea that most of these are going to resolve to normal.
It's going to be a learning curve.
It will be.
And certainly, if there are thoughts that people have about what Ohio AAP and ODH can do for you with learning how we deal with this new test, please let us know.
And
So we
shameless
have
promotion, I actually have a genetic counseling student who would like to survey people who have gone through this process and collect their opinions and data so that we can learn systematically how to approach this.
And we have a DMD question in the chat, so I'll ask that. It says, when do you recommend a repeat test for DMD in premature babies or low birth weight babies?
Any thoughts on that? When to do the repeat screening?
I need to look that one up, because that one, there's a policy that has been arrived at, but I'm not, and it's the best we can come up with without data. And I will get back to you in the chat.
Great. And if you can't, don't worry about that, Nancy. We can also send it out to folks too, right, Mark?
Right, I can include it in the email.
Perfect. So case number 2, we're going to talk here a little bit about, this is where we're going to talk a little bit about the hearing screening, which we have not talked about to this point. So baby Carson is a female infant with a low birth weight born at 38 weeks in Zanesville. She failed her newborn hearing screening in the hospital twice. CMV testing for saliva and urine can be done in the first 21 days after birth. CMV can also develop as late onset hearing loss, so you need to stay vigilant about it. Diagnostic hearing evaluations for all who do not pass newborn screening should be done. The first year of life, as we know, is critical for language and communication, and especially for those of our patients who are getting certain types of interventions, things like cochlear implants, et cetera. That earlier intervention is really, really important for language and communication development. We usually recommend that diagnostic hearing evaluations are done by a pediatric audiologist by 3 months of age. And again, this is one of those mandated by the Ohio Revised Code and it is administered by the Ohio Administrative Code. There are no recommendations on which type of screening should be done, how and which brand of monitor, et cetera. Just that screening needs to be performed, except in the case of religious exemption. So before we move on here, this is very cursory for the hearing screening. We could do an entire webinar on hearing screening, but are there any questions from anybody about newborn screening, CMV, and newborn screening for hearing loss? Talk about one that has a lot of false positives. That's I happen to be on a board for a school for the deaf, and there are so many. It seems like every parent says, we first got this positive test back and we were told, oh, it's probably just a false positive. But then, through repeat testing, it came up. So it's really one of those where follow-up and having somebody dedicated is so critically important on this one, because they can really fall through the cracks if you're not careful. They get the screening done and then, parents will hear from other parents that, oh, it's just a false positive, et cetera. So great question there from Gary. It says, I've heard in some states that the EHDI early hearing screening is overwhelmed. How is it in Ohio? Do any of our panel know? Anybody from ODH happen to know how we're doing on that? How our caseload is doing?
Hello, this is Samantha
We will
Taylor.
get-
I am the state
Oh,
EDI
great.
coordinator here at the Ohio
Oh,
Department of
great.
Health. Yes, I'm happy to report that we are not an overwhelmed system in Ohio. We have the Ohio Revised Code and Ohio Administrative Code really streamlining screening with a 98% reporting rate of babies born receiving that screening inpatient. So we are not an overwhelmed state, but I appreciate you asking, and I'm happy to answer any questions. I can put my information in the chat.
That is fantastic. Thank you so much.
Of course.
So a quick question too here about, is urine more definitive than saliva in diagnosing congenital CMV? I do not know the answer to that one, so we will look that up for you.
And Chris, I'm happy to answer that one.
Oh, please. Great.
Yes, urine is more definitive than saliva because the CMV can be transmitted in breast milk. So if babies are breastfeeding, a saliva may be positive for postnatal exposure. So a saliva is a fine sample to obtain, but if that one is positive, it should be followed up with a urine PCR for CMV.
Great question. So while we're on the question there too, Mark, did you want to pose there? We had a question from Dr. Lazaron there about heart screening that since we have Dr. Gupta-Bazare up.
I have in ABNL heart screen. What do you recommend if the birth hospital does not do echoes on newborns? Would you transfer to an outside hospital or discharge with outpatient echo in 24 hours?
I would say that's a unfortunate, hard reality that it's not always available in a timely manner. What I would say is to consult a pediatric cardiologist and talk that over with them on a case-by-case basis, because there might be other things that they might be able to do or want clarification on. So I would engage our pediatric cardiologist over the phone. prior to discharging.
Great. Thank you. And Dr. Leslie answered the question there in the chat, and Samantha Taylor also put her contacts in the chat. So let's go into case 3. Baby Jokic is a 40-week-old LGA baby born in Toledo following an uneventful pregnancy and delivery. He was discharged at 26 hours of life, and his newborn blood spot was drawn prior to discharge. His newborn screen showed a TSH of 37 microunits per liter. What is your clinical process when this is received? Anybody would like to unmute themselves and say how they would handle this if they have that in their office? Do you have any volunteers? Not a right answer. We're just looking for a tip-off for our discussion. So how would you handle this?
I'm happy to read an answer over the chat too, if you'd rather just enter
That'd be
your answer in
great.
the chat.
That'd be great. So I think most of us would say that if we got this, that we would go ahead and do a repeat. What do resources look like for you? Are you able to do these? Are people finding challenges with thyroid screening? Are there any particular challenges that you guys have with this particular screening as it comes up? There are new recommendations from AAP on thyroid screening. And a lot of times this requires particular support in your office to get this done appropriately, use of a care coordinator, et cetera. Anybody want to share their challenges with thyroid screening? And if not, that's okay. Feel free to reach out to us separately. So let's go to one that's a bit of a sticky wicket. And if you do have questions about thyroid studies, please feel free to chime in there. So this is one where when we were discussing newborn screening, this is not always a really clear process to follow. And sometimes there are ethical considerations. So let's talk about one. A new mother in your practice informs you that her family recently moved to Dayton from California. They have a newborn, and the clinic there told her something like the following. The baby screening is fine, but you should be concerned about ALD for future pregnancies when you get settled in Ohio. The mother did not remember the name adrenoleukodystrophy being used, but she was told this information. So this is, sometimes the way it happens is you get this piecemeal information from a family. Anything in particular we need to know about ALD? Dr. Leslie mentioned this a little bit. I know Dr. Leslie and Dr. Mitchell have some thoughts on this one. So I'll kind of open it up to them. What do we need to know about something like ALD, and what are some of the implications of this?
I think one of the things that I'd be curious about is whether the newborn was a boy or a girl. Because typically, and I would like to get a copy of the screen of whatever they had done in California, to see what was noted and what it was, why they raised this to the mom. But one of the things that we've noticed in Ohio, so adrenoleukodystrophy is an X-linked condition. So it was set up to screen for boys who might be affected with the disorder. But our experience was that initially people being referred to us, and I'm in genetics, so we were getting the babies sent to us after the positive newborn screens. There were a lot of girl babies who were being flagged, and the concern there's potentially that they are carriers for this condition, which of course is not the reason that the test was set up. So this kind of just raised some questions on our end, was that initially I think the first 3 or 4 babies we saw were all girls, and who turned out to be carriers, but then that has implications for family members, and things that kind of were coming up that we weren't initially expecting from a newborn screening test.
So is our role to really to interface with genetics, Anna, to kind of?
I mean, that's sort of where my experience has been with this, is that we get, as it was mentioned in the process, we get copies of the newborn screens from our area that are abnormal. We try to interface with the pediatrician's office and determine whether they have got the family notified, what their level of comfort with doing follow-up labs versus wanting them to come see us in genetics. Some of it also has to do with how the urgency of the disorder and how high the results are, whether we need to see them immediately versus whether we have time. But we are here as a resource. All of the genetic centers in the state are here as a resource to answer questions and help the primary care providers navigate the system and figure out what needs to be done as a next step on any of these newborn screens that get flagged for something.
It's great. So the last case involves resolving cases with ODH. As Dr. Leslie mentioned, this is a big issue. There are a lot of cases out that are handled by ODH. It's quite an amazing process. So let's talk about case 5, and then we're going to wrap things up. So Landon Childers is a 6-month-old male infant in your practice in Ironton. He's in the care of his father with significant help from his maternal grandmother because his mother passed away in a car accident when he was 2 months old. He had a positive blood spot for Krabbe disease, but you had not seen him since that report came back at 1 week. So what is the best course of action now? Obviously, with something that requires pretty rapid attention, and it sounds like this has not happened. So how would you communicate, obviously, with not paying too much attention to the clinical course here? How would you go about resolving this? And any suggestions from Dr. Leslie and Dr. Mitchell about how best to interface with ODH around a case like this, something that's been lost to follow up?
I think if somebody, what the primary care provider wanted, like if again in from genetics, we'd be happy to see the family if they wanted to call us, the genetics center near them, or put a referral in to have the baby seen somewhat urgently to get the follow-up labs done. We'd be happy to assist with that. And just, I think the important thing is getting those follow-up labs to determine, is this a real positive or is it a false positive, so that then treatment plans can be made for the patient and the family. And I don't know how you prevent incidents like this. We can just do our best anytime somebody sees a family trying to determine whether follow-up has happened. I know anytime the family interacts with the medical community, but it can be hard to prevent these things.
And certainly being registered with ODH helps some of this too. So where do you find out what conditions are screened for? Dr. Leslie gave us some great resources here that will be in the packet for you all to look at. babiesfirsttest.org. We talked about advocacy opportunities, helping with in your office, in your hospital system, certainly being advisory, communicating with the advisory council here in Ohio and other places is very helpful in helping make these things become more efficient and effective. There's a lot on the ODH website, and these slides we'll kind of go over quickly here because we're kind of running out of time. If you're looking for one best overall website, our panel of experts recommend babiesfirsttest.org. It's a great site. I've been checking it out since we put this presentation together. And with that, I am going to turn this back over to Mark so he can wrap things up for us.
I'll just mention real quickly, first of all, thank everyone for attending today, and thank you, the panel, Dr. Bowling, Dr. Mitchell, Dr. DeBassere, and Dr. Leslie. This was another great discussion for our PHP webinar series, so thank you everyone for attending and for presenting today. I'll just mention real quickly that I will be sending out more information about how to obtain your CME or MOC Part 2 credit for this webinar. There are a few of our upcoming opportunities for the Ohio AAP at the end of the slideshow here, so I'll also send that out if you're interested in any of our upcoming webinars or programs that you can be involved in. But otherwise, I think we had another great talk today, and I hope that you all have a great rest of your Wednesday. Thank you.
Goodbye, everybody.